Hi, good evening, everyone. This is Ashkan Lashkari. Thank you so much for spending your evening with us as we are going to initiate a really nice discussion on melanoma and the management of stage 2 and 3 melanoma, which has undergone a kind of a renaissance in its approach. Um, for today's discussion, our moderators are Dr. Greg Daniels and Dr. Soo Park from UC San Diego. We're very lucky to have them, and I'm going to turn it over to them in a moment. A few housekeeping issues. This is meant to be interactive. There will be some case discussions. Feel free to uh, uh, use the chat room to leave any questions, and we'll make sure that all of them are addressed. On that note, Dr. Park, Dr. Daniels, thank you. Take it over.
Thanks so much, Dr. Lashkari. So thank you all for joining us this evening. I hope this will be a very informative and educational evening for both you and us. And so today we're going to discuss management of stage 2 and stage 3 melanoma, neoadjuvant and adjuvant treatment options. And all of us are from the UC Melanoma and Skin Cancer Consortium. So for our expert discussants, we have Dr. Joel Baumgartner here. He's a surgical oncologist from UC San Diego. He's also my co-leader for our disease team. Then we have Dr. Gregory Daniels, who's a medical oncologist from UCSD as well. He's my senior colleague on the team. And then we also have Dr. Adil Daud from UC San Francisco, and Dr. Daud is the director for melanoma clinical research there. So feel free to ask us any questions throughout this evening. We have structured it as many different small cases to highlight certain points that have come out through the research that has gone on over the past couple of years. So with that, we're going to talk about neoadjuvant strategies, and then we're just going to also touch on adjuvant for stage 2 melanoma and for stage 3. And with that, we'll dive right in. So we're going to start off with cases, and they're all based on the same patient but have different scenarios. So we have a 63-year-old male with a 2-centimeter pigmented skin lesion on his right shoulder, and a punch biopsy shows that it is a 3.5 millimeter thick melanoma with ulceration, and he also feels some achy fullness in his right axilla. So we referred him to Dr. Baumgartner, who ordered a PET scan. And the PET scan shows 2 enlarged avid right axillary lymph nodes. And we discussed him at tumor board, and someone had told us we should order NGS. So clinically, he is a T3BN2, which is a stage 3C, and he was also found to be BRAF 600 mutated. So Joel, I will pose this question to you first. What are the next steps for this patient?
Yeah, thanks, Sue. I mean, obviously you jump right in with the controversy. I mean, traditionally we would take this patient for a full lymph node dissection up front. He's got clinically positive nodes and no distant disease. So that's traditionally what we would do, but that the landscape is changing certainly, and I think we'll talk about that. But I think he would also potentially be a candidate for neoadjuvant therapy at this day and age.
Thanks so much for that. So you are absolutely right. Just in the past year and a half or so, the largest phase 2 trial reported to date for clinically detectable melanoma, that is either stage 3 or 4, was the SWOG S1801 study. So this trial randomized 313 patients to either standard of care, which is surgery, followed by a year of adjuvant pembrolizumab, or they got 3 cycles of pembrolizumab up front, followed by surgery, and they completed up to a year of pembrolizumab after that. And this was for patients with high-risk resectable melanoma, and the primary endpoint for this study was event-free survival. So, with a median follow-up of 14 months, this trial was able to demonstrate an event-free survival rate of 72% for the neoadjuvant arm versus 49% for the surgery followed by adjuvant therapy arm. And so on local review, there was about a 21% pathologic complete response rate, which is in line with what was seen in a neoadjuvant nivolumab study that was done at MD Anderson several years ago. And so this is a very clean and simple trial, and it showed a significant benefit for the primary endpoint by using neoadjuvant therapy. So I think most of us now would consider this to be standard of care for melanoma with clinically detectable nodes. So Joel, when you are referring a patient like this to medical oncology, how do you counsel patients about delaying surgery? That causes a lot of anxiety.
Yeah, it does. And I think it probably forces the discussion that we probably should have always been having with these patients is, we can clear their nodal basin, at any point essentially along the way. But the biggest risk of these patients is their distant disease. And no matter how good a surgery or how quickly we do surgery, it's hard to say we make a big impact on that, I think. And that's demonstrated, in this trial. So I think we kind of have to counsel them and say, yes, we know you have lymph nodes that are involved. There's a very high risk that you have other disease elsewhere. And if you have a response, which many patients do from the neoadjuvant therapy, the lymph nodes should also respond, and as well as any other disease. So that's kind of how I would phrase it, and then go from there.
Well, if I was a patient, you would have totally convinced me. So we're going to keep going on with this patient. So this patient was rightfully referred to MedOnc and starts neoadjuvant pembro. And after 3 cycles, the patient feels great and the achy fullness in his right axilla has completely disappeared. And he actually does not see the need for surgery anymore. And he cancels his appointment with you, Dr. Baumgartner. And you compromise as the MedOnc and order a PET scan after completing the peer-to-peer review. So the PET scan actually shows a complete metabolic response. And, the original plan was to go to surgery and start adjuvant pembro, but this patient is still refusing surgery and he, still reiterates his really great PET scan results. So Greg and Adil, what do we do now? Is there any prognostic value for a complete metabolic response in a PET scan? How would you manage this patient?
Yeah, well, I think as you alluded to, we do have some information about complete pathologic responses and outcomes. And so, a complete pathologic response, or a major pathologic response, which, has been defined over the last kind of 1 or 2 years, or maybe 3 in melanoma, as being the difference between like no viable cells or up to 10% viable cells or up to 50% viable cells. Those seem to be some cutoffs that correlate with clinical activities. But we don't have really great data for using PET scans yet to guide this. I will kind of say that, imaging underestimates the response rate pathologically. So, that's one thing in the favor here is that you have a PET scan that shows a complete metabolic response. So you're a little more hopeful that that's a pathologic complete response. But, as you pointed out, that pathologic complete response just happens to be very similar to the complete response rates we see with metastatic disease and pembrolizumab by itself. So about 20% of the patients with advanced disease are going to get that long-term off-drug benefit from just pembrolizumab alone. And so that's what I'd tell them, that, yes, it's possible that, they jumped over the bar with just systemic therapy, but I'd still recommend that we do surgery. So, I don't know, Adil?
Yeah, I mean, I totally agree with what Greg and Sue and Joel just said. What I think the issue of how long to treat somebody in this type of situation, we face this all the time. And if somebody has like a lymph node that could be sampled by cytology or sampled by ultrasound, I still favor doing that because it gives you some more information. And at a certain point, if you continue treatment, you're going to have to decide whether are you going to treat for a whole year? Should you wait for 6 months? Do you wait for 2 complete response scans? Which, we sometimes do that in a metastatic setting. If somebody has a complete response, metabolically, usually what we do is we'll get another PET scan showing that it's that you continue to have a complete response, and then maybe at that point consider stopping. I think in some of the older trials, there was the 2-year rule, in the adjuvant setting, there's the 1 year rule. I think some of the issue is just what seems like the most reasonable thing to do. I think in this situation, I've continued treating and maybe try again in 3 months to have another conversation with the patient and say, maybe surgery still might be a reasonable idea, maybe not for a complete lymph node dissection, but maybe a sampling of the lymph nodes so that we get some more information about whether you've got, any residual cells left. And so, yeah, I still favor doing some type of sampling just to get more information so that so it doesn't seem so arbitrary when you just, like 3 months or at some point decide to stop treatment.
Yeah, and actually one patient in the SWOG study, had a complete imaging-based response and declined surgery and has not had a recurrence after 31 months. But again, that's one patient. So we'll go to scenario 2. So we have the same patient. He has a clinical stage 3C BRAF mutated melanoma. He starts neoadjuvant pembro. After 3 cycles, he feels great. The achy fullness in his right axilla has improved, and he proceeds with surgery with Joel. But his pathology shows a 60% viability in the tumor cells that were seen. And this is consistent with a pathologic non-response. And nowadays, there are different categories that we use to grade a pathologic response, as you can see that I've listed here. But before we go further, I want to ask Joel, how does neoadjuvant immune therapy affect the surgical field? I know from the lung data that, some of the surgeons have seen increased fibrosis. Have you noticed anything in these patients?
Yeah, it's a good question. It's still fairly new. So, the handful of cases that we've done, I wouldn't say I see a huge difference, to be honest, in terms of fibrosis. It probably matters a bit more in certain tissues, like the lungs or, maybe a liver resection or something than it might for a lymph node dissection. So I can't say I've seen a real obvious difference.
So based on, there are actually a task force that was developed by SITC where they discussed the definitions of what primary and secondary resistance is to different types of immune therapy. And here it was generally agreed that patients who achieve a major pathologic response, those patients that recur after surgery, they may better fit the definition of secondary resistance, but patients that have not achieved a major pathologic response up front are more consistent with their primary resistance. So for our patient who had a 60% viable tumor cells seen in the pathology specimen would most likely count as primary resistance. So what do we do now for adjuvant therapy? Greg, Adil?
Yeah, so you made it easy because you gave us an option in a BRAF mutated patient. So, that would probably be the first choice here. And there is some data looking at the choices after neoadjuvant therapy and having primary resistance like you're alluding to. And surprisingly, you still get a benefit from PD-1, even if you don't get that great response from PD-1. But it seems like targeted therapies, if they're an option, is probably the better option here. I keep forgetting, when you stage this patient, by the way, if you're getting a PET scan, I would always get a brain MRI. That's just one subtle thing I would throw in there for these high-risk patients. They should always have a brain MRI.
So then I'm going to turn the table and say, oh, Foundation called me and said they're actually not BRAF mutated. They got it mixed up with somebody else. So Adil, what should we do?
Yeah, I mean, I think that's great. I mean, I love the way the discussion is proceeding. What's interesting is that if you look at some of the data about path non-responders to immunotherapy, they seem to benefit too. Like if you look at the path NRs, which is kind of weird, right? Like how could, years ago, I thought that the major selling point for neoadjuvant therapy was that, and that's the way I would talk to patients that say, you know what, if the tumor shrinks, we know this is an effective therapy for you. But, the corollary was if it doesn't shrink, okay, well, we know that this treatment isn't working for you. And maybe we'll escalate and go to combination checkpoint therapy or do something else or change to a targeted therapy. But yeah, I think when I face this type of situation, I I feel like I don't have a very consistent viewpoint. Sometimes I've said, well, let's just wait and see what happens. Sometimes I've just continued with PD-1 anyway and just done what was done in the SWOG 1801 trial. Sometimes I've said, let's just do observation, and then if it becomes metastatic, and then we'll do combination checkpoint therapy. I don't think I've done a lot of combination checkpoint therapy in the adjuvant setting because, you know, there's some data that it may not be as effective. So yeah, I feel like it's definitely a long, lengthy discussion, you know, just looking at the data and seeing, you know, what the patient, you know, what the patient's perspective is too.
All great points. So we're going to move on to our next scenario. So we have the same patient, starts neoadjuvant pembro, but after 2 cycles, he develops pretty bad grade 3 hepatitis. When I say grade 3, I mean on the higher end of grade 3. And so he was started on prednisone with a taper, but then you had to add on mycophenolate because he flared on the prednisone taper, but his hepatitis resolved. So what are the next steps? You know, what would you guys do? Would you guys go straight to surgery, do something else?
I mean, I would go to surgery, probably restage, because by now you might have let 6, 8, or 10 weeks go by, because Joel's probably not excited about taking somebody to surgery that's on high doses of prednisone and mycophenolate. So he'd probably assess them clinically, just guessing, and say, okay, well, you seem to be responding. Let's cool you off a little bit and then restage. Because then if he has a good response, then you're stuck back where you were before. Do you take him to surgery? Yeah, so there's a lot of variables here.
You know, does the prednisone that he's taking, does it have an impact on his clinical outcomes? And what about the mycophenolate? Does that add to it? Because now he's, you know, basically having somewhat of accelerated immunosuppression. And then, you know, would the degree of pathologic response in this patient who's had a pretty bad IRAE influence your decision about adjuvant?
Yeah, definitely I mean, it's a great case, but and one that we face, but yeah, I think also go to surgery because you know, surgery is curative at the, or potentially rephrase that, potentially curative at this phase. And also the SWOG 1801 trial, which was, you know, awesome trial, no quarrels with the design or anything, but it didn't show a survival benefit, right? And so so far, all we know is event-free survival. And event-free survival, I think it's a pretty hybrid kind of endpoint that, you know, may or may not mean a whole lot. And the fact that, you know, you don't get a survival benefit from neoadjuvant suggests that, you know, you could do surgery, and then similarly, adjuvant therapy, we haven't seen survival benefits to date with adjuvant immunotherapy. But the problem, longer term problem, I think that you're pointing to is that what are we going to do in the future with somebody like that? Obviously, giving combination checkpoint is not going to be easy to do in somebody who can't tolerate pembro, and then so you're left with targeted therapy. So the future might hold a lot of challenges, but for now, I think going to surgery makes sense.
So if this patient had a major pathologic response, would you guys just surveil the patient after surgery?
Did Foundation call me and say that he's still BRAF mutated or not? I can't
No,
remember.
he's not mutated right now.
So if it's not mutated, yeah, I'd ignore him. I think if he was mutated, that's a harder one, because he had a great response to immune therapy. These guys usually mark themselves well, but you also know you don't want to treat them again, potentially, if you can avoid it with immune therapy. So do you go ahead and bite the bullet and give him some BRAF if he is BRAF mutated? So I'd probably give him some targeted therapy because I just wouldn't want to see it again.
All great points. So for the next scenario, he'd be BRAF mutated from here on out, I think. So with the same patient, starts neoadjuvant pembro. After 2 cycles, his right axillary nodes are much larger on exam. And this really, you know, makes Joel a little bit uneasy. He's also having more pain in the right axilla. So could we have anticipated this? You know, what are the next steps here?
Well, we do anticipate this. This is our fear, how many people, get neoadjuvant and then either progress and don't go on to surgery, which is not too many. I think in that SWOG study, it was maybe one or two. I can't remember, but it wasn't very much. And so, always we talk about, oh, is this pseudo progression? Are we overreacting to? Typically, if it's causing pain and stuff, I'm not too optimistic that it's pseudo progression. But I think you're going to get into some. Are there biomarkers that we could have used up front to help predict this? So I'll let you go to that.
Yeah, actually, there was 12 patients in the SWOG study that had disease progression and could not proceed to surgery. So, that's a significant number. And I think this just highlights the importance of restaging these patients just to make sure that, their disease has not gone beyond the lymph node basin. But so this was a neoadjuvant study called the Opus Neo study that was done at MD Anderson several years ago. And there were 3 arms or groups to this study. One was, regular dose of Nivo for 2 cycles. And then arm B was flip dose for 2 cycles. And then the third arm was doing 2 cycles of IPI, followed by sequentially 2 doses of Nivo. And they did some RNA sequencing on the pre-treatment tumor biopsies. And, we found that having a high interferon gamma signature or score was associated with a pathologic response, as you can see here, and actually a low risk of relapse. And patients with a pathologic response also tended to have a higher tumor mutation burden. So, when you can combine these 2 observations, the interferon gamma score and the TMB, they were trying to see if the combination of those could better discriminate pathologic responders from non-responders. And so I think this is something that potentially could be used more clinically on the horizon, but I know that we're always looking for biomarkers and nothing has really panned out as slam dunk. I don't know if you guys have heard of any coming on the horizon.
I think, we looked at T cell, we extracted T cells from neoadjuvant patients and looked at them. And I think if you were just trying to predict response to pembro or to PD-1, it's monotherapy, the number of T cells was pretty predictive. But once you throw in like a combination checkpoint, like a CTLA-4, either flip dose or regular dose, we didn't find that the T cell numbers were highly predictive. And then the problem in cutaneous melanomas is that the TMB is so high that, when you have this difficult issue of like is it more than 10, 15, 20, and unless you have acral or mucosal, which have really low TMBs, most cutaneous melanomas are going to be like in that 10 range. So you don't have a lot of discrimination built into just the TMB. And interferon gamma signature, the way it was originally defined in that AIR paper, that's actually hard to do because you have to send it to nanostring and then you have to massage it's not something that is accessible, but you could use PDL1, which is pretty concordant with the interferon gamma signature. But yeah, I think you could use PDL1, and then if you had like a really low PDL1 and really low interferon gamma signature, maybe you would. But then you have this issue that the difference between 39% and 88%, I mean, neither one of them is, are you really gonna make a decision based on that? Or are you gonna say like, just go to Dr. Baumgartner right away? Or are you gonna, it's all these difficult issues. So we've also stopped using the T cell assay partly because, it just was not as helpful and it was kind of a difficult assay to standardize. Yeah, be curious to know what you guys are doing.
I know Greg has strong opinions about biomarkers.
I love biomarkers. I just haven't found the slam dunk one in this scenario. And I agree. I think you get about as much information from just PDL1 percentages from doing nanostrings and all the fancy stuff. But at the end of the day, we don't really know in those people that respond very low, what it looks like. I think, the SWOG study is, I agree, it's a fantastic study. I think there's a lot more information still to come out of it because they I'm not aware, maybe Adil, have they released really any more details on the pathologic responses that they were seeing? And they also have confirmed, so confirmatory samples before patients started. So they're going to have free samples. And so I'm sure they're doing, Tony's assays on this and all the biomarkers. So maybe we'll have some better data, but right now there's nothing that I'm using other than maybe histology, location, TMB, and age of the patient. So all clinical factors kind of come into play.
I mean, I don't know about the SWOG, but I understand that it has local review. And the problem with local review, or at least the problem we have at UCSF, is that, and Michael Tetzlaff has said this several times, it's very dependent on what the surgeon sends to the pathologist. You have like this, you have a tumor. If the surgeon sends representative pieces from all of the sites, including the sites that are no longer present, and you could see the presence of hyaline necrosis and stuff like, okay, then you've got a complete, understanding of how much of a response. But if you just send the piece that's viable, or you see the residual tumor there, and you don't send the rest of the, fibrofatty, I hope I don't sound stupid here, because Joel, correct me if I'm wrong. What do you send to at the after resection?
Yeah, it's a good point, and I think it's often not discussed. Really, it probably is more the pathology side of it than the surgeon side. If we're like in this scenario, if we're doing a full dissection, it's really one specimen. I mean, or maybe two if you divide up the different zones, like in the axilla. But the traditional way that this is done is just a single specimen of all the lymph-bearing tissue from that region. And then that all gets sent to pathology. And then it's really the pathology that, has to sort them, sort of dissect out individual lymph nodes and et cetera. So that's really the way that I certainly try to do it. And I think that's how most folks, still do it. So now I know in other countries, I think in Japan, a lot of the surgeons do their own back table dissection, and they pull out lymph nodes individually and send those separately. And the Japanese are very famous for having all these micro zones within lymph node basins, but we don't do that. Yeah.
And do you have to communicate with your pathologist, or is it pretty much understood? What are you're looking for?
Yeah, it's just sent as a dissection. Sometimes we'll orient it, but other than that, there's very little, communication. I think it's outside the scope of our discussion here, but it also is an important point. When a pathologist does a lymph node dissection, sectioning, they usually just section the lymph nodes in half. They cut them in half, look at them. So where if they do a sentinel node, they're making very fine cuts through that sentinel node. And so, it is possible to miss some disease here too, if it's a small deposit.
Thanks for all.
I'll just make one comment too about pathology. It is important to talk to your pathologist because there's stuff that's not standard that is helpful in melanoma. And so having that conversation, we get this all the time. I'll get, positive lymph node, but they won't tell me how pregnant that lymph node is. And that's important when picking your adjuvant therapies. So getting your pathologist to give you that information is important. And you're right, Adil, on the SWOG, they just reported the complete pathologic responses. They didn't report 10%, 50%. They didn't report any of that stuff because it was all local, and our local people don't do that either. So we don't get that, but we should. It just hasn't worked its way into standard pathologic reporting yet.
So for this patient who did not respond clinically to neoadjuvant pembro, we get a PET scan on him. There's no progression outside the lymph node basin. He gets surgery. And then for this patient, what would you do for adjuvant? And he is BRAF mutated. Just do BRAF? That's what I would.
I think it's a difficult decision, but yeah, you could just do BRAF, I think based on, also I'm going by the way you phrase that question too. hopefully foundation is not going to yank the rug from under you by saying something different too.
Oh, maybe I'll just go to Karis or Tempest then.
Yeah.
So let's go to the next case. So we have the same patient, but he has Crohn's disease. It's well controlled on Humira, and he's actually requesting neoadjuvant targeted therapy because of this. So, what are your thoughts on neoadjuvant targeted therapy? Would you offer it, or would you actually recommend that this patient proceed with surgery?
Hasn't
Well,
really been convincing. Oh, sorry.
I mean, we probably maybe disagree on this one. I actually do consider neoadjuvant targeted therapy in palpable disease. Maybe not for just the radiographic, and we can talk about those issues too. But we have seen good responses, and I don't know if it makes surgery better or worse. We've not had a lot of them, so Joel, so I'm not sure how you feel about it. But targeted therapy has a high response rate. And again, here's another guy that or gal that you're hoping you don't have to give immune therapy to later. So I am trying to think about maximizing therapy up front.
Yeah, I'm not sure that, I mean, the anecdotal ones we've done, I don't think I've also seen, increased fibrosis or difficulty with the dissection. These patients, the interesting thing is if, it's good, and this is why it's good for us as the surgeons to meet with these folks up front to talk about what's going to be the surgical plan. If we're going to do a full lymph node dissection, then it doesn't really matter. But, the question remains, what if, so they got an isolated node, and then we're going to try to just resect that node in the future. What if they have a complete response? That's sort of this earlier scenario that Soo presented. But then it gets into, it's almost like a breast cancer situation. Should we mark the node, and then take that one out later? That's a whole nother discussion.
Adil, are you a fan of neoadjuvant targeted therapy?
Yeah, I mean, I feel like just talking with the surgeon, we had a patient similar to this. The nodes weren't big, and we haven't done the marking, but that's what we ended up doing for this patient, is marking the nodes. I think part of the problem was, unlike this patient, that patient had multiple small axillary lymph nodes. One of them was like, I want to say 1.5 centimeters, but then the rest were PET positive, but we didn't know actually if they were tumor bearing or not. So we ended up giving her or getting them marked. And I think I decided to defer on the neoadjuvant therapy because I just thought that it would be so hard to, they were small. You might make this, and a surgeon said, like, it's not going to be any easier once you do. I mean, if the goal is eventually to have surgery. And so I thought, and basically we haven't treated her adjuvantly either, because she has some autoimmune disease, and I was just thinking that hopefully it doesn't recur, but if it recurs, then maybe we'll do treatment at that point.
Yeah, so there have been 2 studies looking at neoadjuvant dabrafenib, trametinib in the neoadjuvant space. So this was a study, it's a phase 2 trial. They got 12 weeks of neoadjuvant DT for resectable stage 3B to 3C melanoma. It had 35 patients. This study was carried out in Australia. And they also got 40 weeks of adjuvant therapy. And I think what was interesting in this study, as Greg alluded to, for the high response rate, and the pathologic complete response rate was 49%, but they still had recurrences even after path CR, as you can see at the bottom left. And, some of these were, in the brain, outside the brain. So, it doesn't seem to be very durable. The next study, it's a very similar name, just reverse, the Combi-Neo study. This was also a phase 2 study where they got, instead of 12 weeks, 8 weeks of neoadjuvant DT in about the same population. They had fewer patients in this study, 21. 13 patients were in the neoadjuvant arm, and there was a discordance between the RECIST and the path responses. Again, with targeted therapy, they had a high path CR rate of 58%, but this did not correlate with the RECIST response rate. And so what I think is interesting is that treatment with targeted therapy, it was associated with an improved recurrence-free survival and distant metastasis-free survival when compared to upfront surgery. But when we think about neoadjuvant IO or neoadjuvant targeted therapy, this was a pooled analysis from 6 clinical trials of neoadjuvant either PD-1 based IO or targeted therapy. And these are the Kaplan-Meier estimates for recurrence-free survival for the patients that received neoadjuvant IO PD-1 based therapy. And you can see that, if you have a favorable pathologic response, so if you have a path CR, a near CR, a partial pathologic response, you did have an improved recurrence-free survival. But for neoadjuvant targeted therapy, in contrast, when we look at the estimates of recurrence-free survival for patients that got DT, the path CR rate is really important because that confers the best chance of improved recurrence-free survival. So it is a bit discordant when we compare this to neoadjuvant IO. So here we have a second case. So we have a 63-year-old healthy male. He bikes every day. He has a clinical stage 3C melanoma of the left heel. And he saw an outside doctor who recommended neoadjuvant adjuvant pembro based on the SWOG study. But he's seeking a second opinion from you all. Would you recommend this same treatment or something else, and why?
BRAF mutated.
No.
It doesn't matter. I would, I thought, thanks for sending these slides earlier. This is a tough one. But I would go with the SWOG data, and I would treat with neoadjuvant PD-1. You're expecting a lower response rate, and looking through the SWOG data, they didn't have a lot of acral melanomas, and they didn't really call them out either. I think they weren't enough to even be balanced between the arms. So we don't know. We do expect them to have less response rate, but I think neoadjuvant makes sense here, and then you're going to get some biologic response data.
They had 4 acral in the SWOG study, but still too low. Adil, would you give this patient neoadjuvant ipi-nivo?
I mean, we've done that before, but I've had enough, experiences with permanent IRAs to now become kind of shy of doing that because, adrenal insufficiency and type 1 diabetes and even worse stuff can happen. And seems like you see it more often with neoadjuvant, maybe because people are just, have lesser extent of disease and better immune systems. So yeah, I guess it's a tough one. I think I might, if it's an acral, I might just go straight to surgery or do what Greg says, maybe go with the SWOG data. Yeah, I wouldn't be highly optimistic that neoadjuvant therapy would work, basically. That would be my concern. And maybe this is a case where just doing surgery and hoping that surgery gets everything will be a reasonable thing.
Yeah, and as you said earlier, the thing that would sway me too, and sticking with PD-1 is we still don't even know if we're improving survival. So how hard do you want to push here?
Well, it depends on the patient. Some patients want to push very hard, so it's always discussion. So case 3. So we have a 63-year-old male. He has a 2-centimeter pigmented lesion on his right shoulder. It's a 1.9 millimeter thick melanoma with ulceration. He's feeling well. You can't palpate any nodes. At least Joel can't. So he's a clinical stage 2A. And so he gets a wide local excision and a sentinel lymph node biopsy with Joel. So Joel, would you order imaging right now or not? And, would that change management in any way?
Yeah, it's sometimes swimming upstream, but I try to avoid imaging. I try to follow NCCN guidelines as much as I can and try to most of the time talk patients out of getting imaging. If they've done the research, they always will ask for it. So I generally would not do imaging in this case. Of course, the caveat is if they have some, clinical symptom of metastatic disease. So I generally would not.
So this patient did not, and so pathology shows no evidence of primary tumor in the resection specimen, but he did have 2 axillary sentinel nodes, and one actually has an 8 millimeter, which is quite large nodal deposit. So now he's a stage 3B, and for these patients, we know that adjuvant therapy is standard of care. But now that we know that he had an 8 millimeter nodal deposit, because the SWOG study also included patients that had radiographically detected clinical nodes, should we have given him neoadjuvant pembro? And would we have known if we had done a PET scan or some other scan before? So what is our threshold for imaging now to really identify clinically detectable nodes, that are not, readily apparent on exam? Greg?
Yeah. So as Joel said, obviously, if there's any concern, it's a low bar. But this is where I might deviate from the NCCN, right? The NCCN still says if it's a T2, T3, even T4s, so stage 2s, clinical stage 2s, they're not recommending routine imaging. But that would miss some of the cases that were in the SWOG 1801. So I think, the NCCN probably needs to revisit this issue if they believe in the SWOG data, that we probably should be staging some of these guys. So personally, anybody clinical stage 2B and above is an easy one for me because I know I'm going to radiographically stage them later anyways, because that is a recommendation. So with the SWOG data, anybody that's clinical stage 2B or above, I'm staging. Of course, you put this guy 0.1 millimeters away from that. So, then you get into, okay, fine. We make these arbitrary lines, but we don't have to totally adhere to them. And then it's a discussion.
Just to play devil's advocate a bit, though, I would say, on CT, this lymph node would probably look normal. Maybe it would be FDG avid on PET, but maybe not. I mean, 8 millimeters sounds big, certainly, and it is from the adjuvant trial standpoint, but from a imaging standpoint, that's still pretty small deposit. So I don't know if that would have even shown up. It may have.
That was a typo. I meant to put 20. So switching gears to adjuvant therapy. So case 3, same patient as before. He's feeling well. You can't palpate any lymph nodes. He's a clinical stage 2A. He gets surgery in a sentinel lymph node. And his pathology shows that there's no evidence of primary tumor in the resection specimen, and both of his sentinel lymph nodes are negative. And then he comes to you with this report that was ordered by an outside dermatologist that says that based on this DecisionDx gene expression profiling test, that he is a class 2B, which according to here is associated with the highest risk of recurrence and metastasis within 5 years. And so he then asked for a medical oncology referral to discuss adjuvant therapy. So, would you recommend adjuvant therapy in this patient, even though this is a stage 2A patient, especially, this patient is really worried about this test result? And what do you tell patients that come with this type of testing, and do you do it yourself? Adil, I'll start with you.
Yeah, I mean, I think this is the exact reason why we medical oncologists don't order this test, and why I think it's based on a lot of assumptions, that are built into this test. And when you try to separate out stage 2A patients, positive or negative class 2 signature, you basically don't find that in the DecisionDx. That's just not the way it was done. And it's just hard to know if it's adding anything to like a good dermatopathology assessment of the specimen, versus the kind of assessments that are done by dermatopathologists that maybe are not seeing a lot of melanomas, right? And yeah, I think I wouldn't, because it's just hard to know if this is really, whether this 2B class means that if you had a stage 2A with a 2B class, you're high risk or not. I think the way the Castle testing is done, they basically just take all patients and then they say, okay, if you have a 2B, what's your risk? But then that conflates the 2As and 2Bs, and we know that 2Bs and 2Cs definitely have a much worse outcome. So yeah, I would stick to whatever your plan is with stage 2A patients, which for us is mostly observation and just watch them carefully.
Greg, are your thoughts similar?
Yeah, this is always such an awkward conversation because patients come in and they have the report and they've been told that they really need to do something, and we have no idea what we really need to do here. Where Castle has, I think, that's most legitimate footing is, can you avoid a sentinel lymph node in some early stage patients? And so that's where the FDA gave it guidance, but it's being promoted in a lot of different scenarios that lack really good data. So I do try to hold the line if it's a 2A. Again, going back to what Adil said, we haven't proven that we're improving overall survival in patients anyways. We do it for event-free survival or relapse-free survival, but now I have another piece of information that I just don't know what to do with. So it won't. I try not to let it sway me.
And I just want to note that, on NCCN guidelines, gene expression profiling is not recommended to be incorporated into any clinical decision-making at this time. So case 4, so we have the same patient, but now he has a 2.5 millimeter thick melanoma with ulceration. Feels well, no nodes on exam. He's a stage 2B. He did get a PET scan because he's a stage 2B if he saw Greg, that's what would have happened. It's negative for nodal disease, so he gets surgery with Joel. And his pathology looks good. Sentinel lymph nodes are negative, so he's still a stage 2B. But now we know that there is approval for adjuvant pembrolizumab for stage 2B and 2C. So would you treat him with adjuvant? What if this was a T4B or, stage 2C? What are your thoughts on adjuvant in this patient population? Greg.
So it's an option. Again, it's one of those conversations where a lot of times patients come in really biased in favor of one way or the other. And, it's really presenting, I hope I try to do it fairly, which is we have this medication where if we use it early, we can improve the lower the risk of recurrence by a relative 20%. So I usually go through and I make some calculations for them and then discuss the potential toxicities, 15 to 20% needing thyroid supplementation, a year of coming to the cancer center, blah, blah, blah. And then sprinkle in a little, we're not sure it's actually is the best time to do it early or late in terms of this therapy. And I'm finding that about, I don't know, half the patients in my practice tend to go with doing an adjuvant proactive something. And the other half tend to say, thank you for letting me know, and go on with observation. So I don't know how your practice Adil is.
Yeah, I think just one of those things where you just have a lengthy conversation, and yeah, the fact that we don't see like an overall survival benefit in stage 3 has kind of dampened my enthusiasm for moving this into earlier and earlier settings, because I feel like a year of treatment is pretty extensive, and you're going to unmask some adrenal insufficiencies and diabetes and some other immune-related adverse events. And is this the right time to do it or later? I mean, I think if we had a clinical trial open or if we had something like that, I would definitely try to steer patients in that direction just so that we can learn more, because it's such an unsettled and unclear space as to which. But yeah, like similarly, I also noticed that some people are like, hey, I want to do everything I can possibly do. And some people are like, quality of life is important, survival is important, but not prevention. I'm willing to be followed carefully. And I think for those patients, we could just wait and see.
Yeah, so there was an updated interim analysis that was published not too long ago for this study. And, the adjuvant pembro, it continues to show recurrence-free survival and distant metastasis-free survival benefit. The data is still immature, and we're waiting for the final analysis that has the overall survival data. But over time, the number needed to treat has gone down. I know the absolute benefit for this study is small. It's actually about 13%, and the chronic endocrine toxicity is about 20%. So, there is the argument of, maybe it does, maybe it's not actually helping in the way that we want it to. But that makes me, want to ask you guys, what do you guys think about the phase 3 Columbus AD study? So that's going to be an adjuvant targeted therapy study in this exact same patient population.
Yeah, targeted therapy is interesting. I mean, over the time, I was kind of a little bit of a nayer for targeted therapy in this scenario, but honestly, the targeted therapies in stage 3 disease, the event-free survival, relapse-free survival looks pretty good, and it maintains. And so I am a little confused now about targeted therapies and how good they are in the adjuvant setting, and maybe they do have a little bit of magic. And I will say I totally agree with Adil. I do encourage clinical trials in this scenario. I think we forgot to kind of plug that because we still don't quite know what to do here.
So we'll go on.
Sorry,
Oh, no.
Sue.
Go
I
ahead.
could make one comment. Yeah, what we haven't heard from you. What would you do in this situation? Would you go ahead and because I feel like it's a tricky area, right? Like in stage 2.
Are you asking me?
Yeah, I'm asking you.
Well, if you know me, I'm on I want to do everything. So I don't, obviously try to put my views onto the patient, but for myself, I would want it, but I would, talk to the patient about how, we don't really have any survival data yet. It's probably going to be a long time until we do. The chronic toxicity is real, and is, the benefit is actually quite small. So I think it really depends on what type of patient you are.
I think we're never going to get survival data, honestly, because
Probably not.
therapies are always evolving and changing. And the only studies that have ever shown a survival advantage were either, the Europeans that can restrict access to therapies so they can't switch over to the really active stuff. That's what they showed in their Ipi-Nivo study. Or yeah, we're getting more tools. And so, this elusive thing where, again, that's the whole point of adjuvant therapy is we're making people live a longer, healthier, better life. But I'm not sure we're ever going to be able to prove that.
But I think even if you can't prove it, then maybe we have to rethink our primary endpoint. Maybe, not being anxious about recurrence contributes to quality of life, and that's not necessarily associated with
That's
overall.
where these pathologic responses come in and stuff. We will get some, maybe some data to help guide some of this. But I think that the gold standard of overall survival is probably going to elude us for the next ever.
I actually have a quick question. Sorry to add to this, Sue. Did the Keynote 716 do subgroups of 2B and 2C? And if so, did the 2C have more of a benefit than 2Bs?
So actually, in the very beginning, it looked like the 2C had even less benefit. There was more 2B in the study than 2C. I think there were about 300 2B and like 170 2C. But as time has gone on, they've also seen the benefit in the 2C. So it has appeared with time. So for case 5, so we have the same patient, and it looks like he has stage 3B BRAF mutated melanoma. So he's referred to you for adjuvant. So, now we have 2 options. We either have PD-1 or we have targeted therapy. Is there a preferred option here in the stage 3 setting? And, how do you decide? Adil.
So you put a lot of really complicated and tricky situations, and I don't know if I have a real opinion on this. I think some days I think that targeted therapy is reasonable. I think if it's a younger person, like maybe female, I think I favor targeted therapy partly because I think you might have more chance of immune-related adverse events. And then if you're in your 30s, you're going to be stuck with them forever, while, you could tough out 1 year of target therapies, which is kind of like much more immediately toxic day to day, with fevers and chills, etc., from dabrafenib, trametinib. But once you're done with that year, you could be done with the treatment, and then you could go back to your life with very little chance of having forever toxicity. While with immunotherapy, yeah, it's not difficult on a day-to-day basis. But then if you're one of those people who has adrenal insufficiency or persistent diarrhea after you stop, which that could be a problem. But yeah, I think clinical trials maybe is a reasonable, but I know that's a cop out. But I think it's reasonable to have a discussion.
Yeah, I agree. I mean, unlike you say stage 4 disease, where we know the right one to give, if they're equiposed, we just don't know here. But as Adil's saying, it's usually not equiposed for the patients. They usually have some lifestyle preference or some underlying, medical issue or something that might favor one or the other. And so I kind of am relying more and more on that rather than my just inherent immune therapy bias.
Yeah, I think we try to think of administration, toxicity, and comorbidities. This was a multi-center retrospective cohort study that involved international sites as well that was just published. They had nearly 600 patients across 15 institutions, and they looked at efficacy and toxicity for an adjuvant targeted therapy and adjuvant PD-1. And so you can see the survival outcomes and the adverse event table at the bottom. So it looks like targeted therapy had better recurrence-free survival with a higher short-term toxicity, but lower persistent toxicity, as Adil was mentioning. And the overall survival was comparable to PD-1. But the proportion of distant mets among patients who recurred was actually higher in the targeted therapy, and that's kind of echoing some of the data that we saw in the neoadjuvant space. They did subgroup here, and they did find that targeted therapy was better in the female population. So that's something that was really interesting that you highlight, Adil. So, I mean, this is a retrospective study, so we just have to take it with a grain of salt, but nonetheless interesting. So case 6, so we have a stage 3 melanoma, but the pathology shows a 0.8 millimeter nodal deposit in the sentinel lymph node. Patient is coming to you for adjuvant therapy. What are your thoughts on this patient? Early stage primary that's non-ulcerated and has a 0.8 millimeter deposit.
I was hoping we could end with some easy questions. But yeah, this is another one of those brain twister type things where there isn't an easy answer. And I feel like I've changed my position on this many times. And this instant, I side on the side of treating, maybe with adjuvant PD-1, but again, without a lot of really solid data. I think here the true risk of recurrence is pretty low, as we all know. So does that even make sense? Because many stage 3As like this stage 3A, probably if you look at the data, is going to be less likely to recur than the stage 2B patient that you presented a little while ago. And so in that case, is it really justified? You might be going down from 22% to 12% or something like that. And is that enough to justify? I think in many cases it is justifiable, but in most cases I think it isn't. But it depends on what that patient wants, thinks. If the patient is willing to be on a rigorous follow-up program, that might be a reasonable thing too.
Yeah, most of these patients I'm not treating with adjuvant. I go through exactly the same discussion again, but it's tilted a little bit more towards, you really want to do this? So most of the patients I am being a little guiding on this one and making sure that they really want to roll the dice, because I personally wouldn't do this to myself.
So then what if the primary is a T1B, so it's ulcerated? It's still early stage, but everything else is the same. Would you feel the same?
Yeah, I do rely on the calculators a little bit to give me the percentage. So, if it's ulcerated with the 0.8, it's probably going to come out to like 16%, 5-year recurrence, something like that, So then you subtract your relative 20% and you get down to like 12%, So what's the difference between like those numbers? And it becomes kind of meaningless to me.
So then what if,
And
you know,
again, because we don't know survival, we don't know early versus late, and you're treating a lot of patients with this type of disease that would have never recurred, and you're just giving them toxicities.
on the
And I
flip
think,
side, yeah, go ahead, Adil.
no, I was just going to say that, I think we were talking earlier on about the fact that, we are probably never going to see survival differences. And that's great. That's because there's a lot of salvage options. But another way of restating that is that, with today's treatment, whether you get it early or late, it probably doesn't impact your survival as far as we can tell. So I don't think there's a wrong answer here necessarily. It's just, is the patient, maybe gonna go on a 5-year hike through the Amazon and then comes back with heavily metastatic. Or if a person is willing to put themselves through the follow-up process, I think that's not a unreasonable option,
And then I changed the last scenario here to have the sentinel lymph node deposit to be less than 0.3. And that's because there was this study that was published 2 years ago. This was a multi-center international retrospective analysis. This is also cited on NCCN. They had over 3,600 patients with early stage primary melanoma, so T1B, T2A. And they were trying to identify the high-risk patients within the stage 3A cohort based on the burden of sentinel lymph node metastasis. So on the left side, you can see that the nodal risk based on the sentinel lymph node cutoff of 0.3 millimeters. So if you were 0.3 or higher, you were considered high risk. If you were less than 0.3, you were low risk. And on the right side, you can see that the low risk group, they actually didn't really have that much of a difference in disease-specific survival, disease-free survival, and distant metastasis-free survival when you compare them to the stage 1B cohort. So I know that there are some physicians who are actually following the patients that have less than 0.3 millimeters in the node, more like stage 1B, so no, clinical surveillance. I don't know what you guys think about that.
I mean, there's a similar data set for the 1 millimeter cutoff, and that's kind of what I've been following. So whether it was 0.8 or 0.2, I'm thinking about them the same way. Pretty good outcomes.
Do you think we can discriminate better within that? Like 0.3, 0.5, or do you think it just does not matter?
Yeah, maybe with cell-free DNA, maybe with some, new information that, but I'm not sure we can get much more out of that lymph node. Maybe some immune subsets out of it. But yeah.
And then I'm just going to quickly go through this case. This is the last one. So this is an example of a patient who has a stage 4 melanoma. So this patient has a solitary right upper lobe lung met and underwent lobectomy, and his post-operative PET-CT had no evidence of disease. And so for these patients, we know that, for resected stage 4 disease, they have a very high risk of recurrence even after surgery. And so there was the ImmuneEd study. So this was a double-blind placebo-controlled study. It was actually 3 arms. It's a neoadjuvant study of ipi-nivo or nivo alone or placebo. No, I don't think it was an adjuvant study. So with the ipi-nivo, there was an improvement in overall survival, but this was using the traditional dosing. So I don't know if any of you guys do this, give ipi-nivo in resected stage 4 oligometastatic disease. And if you do you dose ipi-nivo, ipi-3, nivo 1, or do you dose ipi-1, nivo 3? And should we have considered this in the neoadjuvant setting?
So just again, a word of caution. So, yeah. So you say, oh, well, Daniel just said you don't get an overall survival from adjuvant therapy, and here you got one. But most of the patients that were in the placebo arm and the PD-1 arm, they didn't get access to ipi-nivo later on, at least in the study. So it's not a totally fair comparison between early and late ipi-nivo exposure. So again, if most of your patients aren't getting your best therapy, it's not a surprise that you might see a survival advantage. That said, I have given ipi-nivo in the adjuvant setting in this scenario where you got resected stage 4 for oligometastatic disease in a healthy person. If they're a little bit less healthy, I might still consider PD-1, but love to hear what Adil's take on this is.
Yeah, there was that negative. I also plead guilty, but there was that. I think there was a study with ipi-nivo versus nivo monotherapy in the adjuvant setting, right? And that study was negative. So I do think that this study is just an outlier, and probably has to do with the small number of patients. I think in the situation where you had a isolated brain met, and then it was taken out or gamma knife, I think in that situation I have used standard dose ipi-nivo because only to try to avoid more recurrences. But I think in the lung met situation, if that's I think I've used like pembro or single agent PD-1.
All great points. I learned so much from you guys. I think we are at the top of the hour, perhaps 5 minutes, a little past, but we're happy to answer any questions. If anybody has them, you can unmute yourself or drop it in the chat. But that was my last slide.
Thank you, Sue, for making us sweat.
Yeah, great questions where there was no easy answer and nothing that we could possibly no wrong answers too, I think.
Well, I do not see anything in the chat, and I don't see anything else. So thank you all for joining us. I really learned a lot. And I'm sure Nicole has my contact information and the rest of us all here if you have any questions later on. So I hope you all have a good night. Thanks so much for joining.
Do you want to say something?
Thank you, Dr. Park. Thank you, Dr. Daniels. Thank you. That was a wonderful discussion. Have a good evening, everyone.
Thank you.
Thank you. Good night.
Bye-bye.